Hi, my name is Ashley Meehan, and I am a part of the National Healthcare for the Homeless Council's Homeless Mortality Working Group. In this video, I will outline why we need housing and homelessness status on our death certificates. So how's this for an opening question? What happens when we die? Well, many things, but the thing I'm going to focus on here is the completion and certification of our death certificates. At a local level, funeral homes, medical examiners, coroners, law enforcement, healthcare providers, and more work together to determine a cause of death, talk to next of kin, and complete the death certificate. Next, the state or territorial health department reviews the death certificates that have been filed by the local registrars. The state or territory may ask for amendments or more information before submitting the information to our country's national agency that tracks and manages death information, the Centers for Disease Control and Prevention, or CDC. Then, at a national level, CDC reviews and finalizes the death certificates and is also responsible for analyzing and publishing information about population change and causes of death for our country. Now, it's important to know that our death certificate is standardized across the country. All people have the same form filled out, no matter who they are or how or where they die. The current version of the death certificate has been in use since 2003, so for the last 20 years. And the death certificate has no designated space to indicate if someone was experiencing homelessness at the time of death. The form captures information about education, Hispanic ethnicity, race, occupation, and type of business or industry. But there's no information about housing status, housing type, or homelessness status, aside from the fields to list an address. So hopefully you're starting to wonder, or maybe already asking, why do we need housing or homelessness status on our death certificates? And to that, I say, great question. There's a bigger picture why, and then there's tangible actions that can shape why. Bigger picture, let's think about housing and health. I think at this point, we can say that we all know that our housing, both its presence and its absence, and the stability and quality of it, influences our health in many ways. Research has consistently shown that not having a house at all, or having a house that is unsafe or unstable, is worse for our health than having safe and stable housing. But there's also a pathway where our health influences our housing, or lack of it. If someone has an illness or injury and they can't work or maintain their employment, how are they supposed to afford safe and stable housing? If people cannot afford safe and stable housing, then their health may worsen, just perpetuating the cycle. Okay, so if we had homeless mortality data, and I have an asterisk here because it's not just any homeless mortality data. While any homeless mortality data is better than no homeless mortality data, ideally we would have timely, complete, and accurate homeless mortality information. Timely, complete, and accurate homeless mortality data would allow us to uncover disparities, inform funding, guide policy, identify trends, improve detection and response, and expose crises. I really like the visualization of this as a blended spectrum for uses. These aren't mutually exclusive uses either. For example, identification of trends may be used to also inform funding, it may also uncover disparities, and uncovering disparities may elucidate inequitable trends or patterns or things that we can resolve through our policy and funding. So let's explore these uses, both already underway and hypothetical opportunities. First, we can use homeless mortality data to uncover disparities. We've seen this done in places like the state of Minnesota. The Health, Homelessness, and Criminal Justice Lab at the Hennepin Healthcare Research Institute merged Minnesota statewide death data with data from their statewide homeless management information system and with data from the census to explore deaths among people experiencing homelessness and compare characteristics and causes of these deaths to those in the general Minnesota population. Having homeless mortality data allowed them to uncover a few critical disparities. First, that people experiencing homelessness have a rate of death that is 3 times higher than those in the general population. Second, that 20-year-olds experiencing homelessness in Minnesota have the same rate of death as 50-year-olds in the general population. Third, that American Indian people experiencing homelessness have higher death rates than other people experiencing homelessness, and a 5 times higher death rate than the general Minnesota population. And fourth, deaths from substance use are 10 times higher among people experiencing homelessness than the general Minnesota population. The Minnesota team has since been using these findings to shape their public health, healthcare, and homeless service efforts, and to seek additional funding and prevention opportunities. Next, we can use homeless mortality data to inform funding and guide policy. Now, this is going to be a hypothetical example that is probably overly simplified, but when I gave this presentation to an audience of mostly homeless service providers, they affirmed that this is aligned with things that they experience often in their communities. So let's say we were in a community that did have really great homeless mortality data, and say we're looking at those data regularly and we noticed that there were numerous homeless deaths classified as accidents on or near a railroad. We then might ask, why is that happening? What's going on? Why are these deaths occurring among this population in this specific location? So, pretend we do some investigating into why these data are the way that they are. Why are these patterns occurring? In our investigating, we realized that there has been an increased effort to clear encampments, and one of the few and only places that people are able to find refuge is near this busy railroad. We could then use our homeless mortality data to tell the story and paint the bigger picture around changing local policy and practices, and potentially refocus funding and efforts on rehousing instead. We can also use homeless mortality data to identify trends and patterns. So just like in the previous example, homeless mortality data would clue us into a pattern that's worth investigating. One example of this is looking at seasonal trends and patterns in homeless deaths. Reports from Sacramento on the left and Alameda County on the right include homeless deaths over different weather seasons. Both locations found that winter months had the highest amount of homeless deaths, but that generally, deaths were pretty consistent over the course of the year. In Alameda County, they note that there wasn't a clear correlation in deaths by month, which could have implications for planning warming, cooling, and other day shelters. Alameda County also reported that the highest number of homeless deaths occurred in the month of August in the year of 2021. Seeing these trends allows both communities to examine their current policies and procedures and identify where preparedness and planning may be adapted. There's also an example of using data to inform funding and guide policy. And as I mentioned before, many of these uses go hand in hand. We can also use homeless mortality data to improve prevention, detection, and response. As someone trained in public health, those are key public health functions that catch my eye. So, having homeless mortality data would help us identify where there may be individual level or facility level opportunities to improve prevention, detection, and response. During COVID-19, we could have used these data to assess if temperature screening upon entry to a shelter was necessary, or if certain bed spacing or sleeping arrangements were protective against COVID-19. We could also improve our efforts around vaccination, testing, and treatment for different conditions. Homeless mortality data could clue us into infectious diseases. Perhaps people experiencing homelessness are dying from vaccine-preventable diseases, and we need to figure out new ways to increase vaccination. Or homeless mortality data could tell us if we need more testing or prophylactic measures in place for certain conditions, illnesses, or pathogens. It's also possible that homeless mortality data could help with contact tracing. During COVID-19, research came out that showed traditional contact tracing was not an effective strategy for people experiencing homelessness. If we had homeless mortality data, we could then look through homeless management information systems and see if that person had been moving through the shelter system and who else might need to be notified of a potential exposure. And homeless mortality data could open our eyes to health issues that may get forgotten or that are not talked about. We talk a lot about substance use, and that is because it's a big issue. But people experiencing homelessness are also dying from things like cardiovascular disease and complications from diabetes. Homeless mortality data could help us identify where more screenings are needed and how we can incorporate those into existing workflows. Lastly, we can use homeless mortality data to expose crises. As part of my work with the Homeless Mortality Working Group, we've been reviewing publicly available homeless mortality reports, which are often the product of local jurisdictions who have done a lot of work to determine homeless mortality in their community. Now, there aren't very many places doing these reviews, but among the places that are doing them and publishing cause of death information, all of them conclude that substance use and overdose were the leading cause of death among people experiencing homelessness. Now, this could be because most of the data used in these reports rely on medical examiner information, which does skew towards accidental deaths, which includes poisonings and overdose. But even in states using vital records, like Minnesota, we're still seeing this trend. I think many of us working in homeless services or in the health and homelessness space aren't surprised to see substance use and overdose as a driver of mortality. However, it also doesn't seem like we're responding to overdose deaths in this population in a way that acknowledges the crisis that this is. If we had better homeless mortality data, we could use that to amplify the crises around substance use and overdose. So, let's revisit the assumption that I laid out for us earlier, that our housing situation influences our health and that our health influences our housing situation. If we add in homeless mortality data, we could improve the health of people experiencing homelessness. We could change our local policies and practices. We could open shelters year-round. We could tailor our efforts to focus on observable disparities. We could improve prevention and early treatment of conditions. If we improve the health of people, we may be able to improve some aspects of their housing outcomes. Now, we know that improving people's health isn't going to magically create new housing options or influence the affordability of our housing, but it could contribute to employment success and financial security, which for some could make a huge difference in their housing situation. Again, this public health framing and approach has its limitations and is only one way of thinking about homeless mortality and the future directions. But considering that public health departments and agencies are the ones tracking deaths, it seems that this is the right path for us to be focusing on to improve homeless mortality data. All right, so now what? Do you think I've convinced CDC to change their death certificate form? Theoretically, I may have convinced some people, but I don't think our federal partners are convinced that the time and effort and resources it would take to revise the form to add a housing or homelessness variable is worth it just yet. Because of that, we've got to start building from the ground up, meaning start locally. I hope that people are watching this video from multiple different sectors and agencies, because this is a whole community opportunity. I've tried to identify and frame 6 action steps that anyone can build on, regardless of your scope of work. First, start tracking mortality data in homeless management information systems and other program data. This isn't on the slide, but this could also be extended to healthcare facilities. Start tracking homelessness status in a systematic way across your facility. Next, help people share their stories in the community and on social media. Storytelling is powerful. Some of you may know that at National Healthcare for the Homeless Council, we like the phrase, "Nothing about us without us." This is a great way to raise awareness and shed light on the issue of homeless mortality and honor the lived expertise that people are bringing to the conversation. Next, start or support a Homeless Persons Memorial Day event and invite the media. Visit the National Healthcare for the Homeless Council's website to learn more about what Homeless Persons Memorial Day is and how you can get involved. Also, local news media are our allies. They can help us spread the word to so many different audiences. Invite them into this work. Next, engage with local public health, medical examiners and coroners' offices, and the local continuum of care, which is one of the primary organizing bodies for local homeless service response systems. These are 3 key players in starting homeless mortality work at the local level. If you don't belong to any of these groups, try reaching out to all 3 and ask about who is doing what and how you can support them in regards to homeless mortality. One thing that I've learned from our homeless mortality working group is that this work is so heavily dependent on positive relationships across institutions and systems. If you have these relationships in place already, that's awesome. For communities with these partnerships, talk with them and consider starting a homeless mortality review. We've got a homeless mortality toolkit on the National Healthcare for the Homeless Council's website and are always glad to chat with folks looking to start this work. And lastly, consider joining our homeless mortality working group. Instructions are available on the National Healthcare for the Homeless Council's website for how to get connected. The more people we have doing this work at a local level, and doing this work consistently and similarly across jurisdictions, the better chance we will have at making this work more mainstream at state and federal levels. Thank you all so much for your time. I hope those of you watching are feeling convinced by why we need this information and that you're able to brainstorm ways for your community to start or maintain homeless mortality efforts.